Hello friends, in this lecture we are going to understand the effect of estrogen over the uterus. So let's get started. Effect on uterus. So as far as the estrogen is concerned, is basically proliferate the growth of the uterus. So it increase the size of the uterus by making changes in the endometrium and myometrium. So first the endometrial changes, it increase the proliferation of a stroma that is situated inside endometria. Second one, it increase the development of the glands. Right? Now in order to change the myometrium, it increase the thickness of the myometrium no matter what. Right? So it increase the amount of uterine muscle. So basically it causes hypertrophy as well as hyperplasia of the uterine muscle. It increase the amount of the uterine muscle. It also make a muscle to become more active and more excitable. In order to do that thing, what estrogen do, estrogen will increase the frequency of the action potential in the individual fiber, and it make the uterus more sensitive to the oxytocin. So how the estrogen causes uterus to become more sensitive to oxytocin? It is not by increase the amount of oxytocin secretion, rather it increase the receptor of the oxytocin that is present over the uterine musculature. So prolonged exposure of the estrogen alone, see during the pregnancy there are prolonged exposure to estrogen as well as progesterone, but in some cases if there is a prolonged exposure to the estrogen, it indicates the risk of the development of even endometrial cancer. Got it? So now let's discuss about the effect of vagina and the external genitalia. So as far as the external genitalia is concerned, it basically causes enlargement of the labia majora and labia minora. There is a deposition of a fat in mons pubis. And as far as the vaginal epithelium is concerned, what it do, it will convert the cuboidal to the stratified type. So basically estrogen will causes vaginal epithelium to become resistant to the infection. So in some times what they do, they give the estrogen, doctors give estrogen in order to prevent the vaginal infection. So vaginal infection in children can often be cured by just administration of the estrogen simply because of the resulting the increasing the resistance of a vaginal epithelium. So by converting the cuboidal to the stratified type of the epithelium, estrogen will ultimately causes resistance to the trauma or even infection. Now what are the effect of estrogen over the secondary sexual characters? Let's discuss one by one. First is the feminine body configuration, then the skin, then the voice, then the hair distribution changes, and in the role in the acne. So as far as the feminine body configuration, what estrogen do, estrogen will do female distribution of the fat basically in the breast and the buttocks. See, in female there is accumulation of the fat inside breast and buttocks are there, while in case of the male the fat distribution is basically over the abdomen. Secondary sexual character changes will be take place at the shoulder and the hip joint. It narrow the shoulder and broad the hips. Got it? And basically funnel shape of the pelvis will appear in male, while in case of female it becomes ovoid shape. Right? So this is the difference between the pelvis of male and female. In male it is basically designed to bear more weight, so it become narrow and funnel shape, while in case of female it converted into the oval shape. Now next thing is that the thigh is basically converge and arm are diverged. It is known as a wide carrying angle. Now what is this thing? Let me show you on a picture, you can easily understand. See, in the normal person and see the cubitus fulgus, this is the divergence of the arm, right? Now let's see this, what are the changes take place in the skin. Basically because of the estrogen the skin of a female becomes soft. Now as far as the voice is concerned, it causes larynx to remain into pre-pubertal portion, so voice stay high pitch. Right, when in case of male it causes the hypertrophy of a laryngeal muscle, it causes low pitch of the voice. Now, as far as the hair distribution is concerned, there are less body hair and more scalp hair in female, and pubic hair, basically flat top pattern is seen, while in the other word it is also known as a apex down pattern. Let's see, this is the male and female. See, in female there is a flat top, in case of male there is a flat down. In the other word, in male the apex up pubic hair distribution, and in female apex down pubic hair distribution. Right. Now, as far as the acne is concerned, the estrogen will causes increased fluid secretion in the sebaceous gland rather than mucus secretion, so there are more fluid, so the chances of to develop acne is decreased. So estrogen itself is act as a anti acne. Alright. Now let's discuss the effect of on the bone. So this is very important one. As far as the effect of estrogen over the bone is concerned, what it will do, it will inhibit the osteoclastic activity. Now what osteoclasts do, we already discussed in the calcium metabolism. Osteoclasts are basically the bone resorptive cell. So by inhibiting the bone resorption is basically stimulate the bone growth, and this inhibition of the osteoclasts is basically stimulation of the osteoprotegerine. Now if you go through my lecture of the calcium metabolism, then you might already know what is osteoprotegerine. Osteoprotegerine is nothing but a ligand that bind with the precursor of the osteoclast and will prevent the conversion of the monocyte into the osteoclast. If you do not know what is osteoprotegerine, go through my calcium metabolism lecture. So basically by stimulating the osteoprotegerine, it inhibits the bone resorption by decreasing the formation of the osteoclast. Second thing it will do, it will rapidly increase height at the puberty. Now this is the different thing. Increase in the height at the puberty, so basically it increase the growth of epiphyseal. It used epiphysis more speedily, so the growth become more pronounced at the puberty, but actually the epiphysis is utilized very rapidly, so actual height of a female is usually less than actual height of a male. Got it? So rapidly unite the epiphysis with the shaft of the long bone, and effect of estrogen in female is more as compared to effect of testosterone in male, and growth of a female is usually ceases after several years earlier than the growth of a male. So in puberty, female looks taller than the male because of the effect of estrogen, but as the time passes inside the female, the epiphysis is actually fused with the long bone, it is basically utilized, and the actual height of a female is rather less than the actual height of a male. Got it? Because of the effect of estrogen is faster in fusion of the epiphysis as compared with the effect of testosterone in the order inside the male. Second thing is that it prevents the osteoporosis. So osteoporosis is basically present in old age, in after the menopause. So after the menopause, almost no estrogen are secreted by the ovaries, so all the effect of estrogen that we listed in our earlier slide are reversed. So increase osteoclastic activity in the bone. Second thing, decrease the bone matrix, and finally decrease the deposition of the inorganic component of a bone, that is calcium and phosphate. So it basically greatly weakens the bone and leads to the bone fracture. So this one is the figure of the bone osteoporosis, and ultimately it leads to the fracture of a bone. Now mechanism of action of the estrogen. Now as far as the mechanism of action of estrogen is concerned, like other steroid, it act by receptor of estrogen is actually present inside the cytoplasm, inside the cell. So estrogen will diffuse through the cell membrane and attach to the receptor that is present over the cytoplasm, and it causes hormone receptor complex. Got it? And this hormone receptor complex will ultimately entered inside the nucleus, and over the nucleus it will bind with the HRE, hormone responsive element of the DNA. So by acting on DNA, it initiate a new RNA or new mRNA synthesis. There are two type of the estrogen receptor, one is alpha, another one is beta. Now one more thing, there are some rapid action of the estrogen are also there, basically the feedback effect on the gonadotropin secretion. Got it? So most of the time steroidal action takes longer period of time to make their action, but this feedback inhibition will be very rapid. So it has a estrogen also has a some cell membrane receptor also. So this feedback effect on the gonadotropin is basically by receptor that is present over the cell membrane, and it produced by intracellular MAP kinase pathway. Now you already know what is MAP, right? MAP stands for mitogen activated protein. Got it? This is all about the mechanism of action of the estrogen. Now let's discuss the next hormone, that is progesterone. Let me show you a diagram of the progesterone, the picture of the progesterone. So it is basically 21 carbon steroid, and it is secreted by corpus luteum and placenta. So in luteal phase, corpus luteum will secrete more amount of the progesterone, and inside the placenta it also secrete higher amount of the progesterone in order to preserve the pregnancy. Now let's see the synthesis of the progesterone. You guys are already familiar with the steps of a synthesis of a progesterone. See, this one is the cholesterol, 27 carbon molecule. First thing that will do it, desmolase enzyme will work. It will break the chain between 20 and 22 carbon, and it will make this molecule known as pregnenolone. What it do, it will just remove this 6 carbon side chain, and now we get 21 carbon atom. This one is the pregnenolone. Now inside the pregnenolone, what it will do, after that its 3 beta hydroxysteroid dehydrogenase will remove the hydrogen atom at the third carbon, and we get our progesterone. Alright, now let's discuss about the effect of the progesterone one by one. Effect over the breast, then effect over the uterus, then effect over the fallopian tube, then effect anti-estrogenic effect. Now this effect is very much important. We are going to discuss in very detail in our subsequent slide. And the last one is the thermogenic effect. Now as far as the thermogenic effect, there are multiple times comment is asked that is progesterone will leads to increase body temperature at the time of the ovulation. What is the degree? It is 0.5 degrees Celsius post ovulatory phase. Got it? So what progesterone do? Progesterone will increase the body temperature at 0.5 degrees Celsius after the ovulation. So this is also the sign of ovulation. So the comment that I mentioned earlier is like that, increase in the body temperature after the ovulation. What you have to write it down if such kind of comment asks. See, first thing first, after the ovulation, there is increased production of the progesterone. That progesterone has a thermogenic effect, and it will ultimately leads to increase basal body temperature at the time of the ovulation, is basically 0.5 degree post ovulatory phase. Alright. Now the important one, the effect over the breast. Progesterone will promote the development of the two things. One is the lobules, another one is the alveoli. See, in this diagram, these are the alveoli, this one is the lobule, and this the duct development of the ductal system is basically designed by increased by estrogen. So remember that the ductal system development is done by estrogen. Alveolus and lobule will be increased by progesterone, and again this deposition of the fat is done by estrogen. So estrogen will do two things. One is deposition of the fat and development of a duct. Progesterone will do two things. It will develop the lobules and alveoli. These are the lobules and alveoli. So alveolar cell will proliferate, it become enlarged and become secretory, but it does not cause alveoli to secrete milk. Milk secretion is only and only stimulated by prolactin. Remember that thing. Now effect on internal genitalia. So as I told you earlier that progesterone is basically made to preserve the pregnancy. It prepare the uterus for pregnancy. So it basically prepare the uterus for implantation. So if there is a fertilization, then this fertilized ovum should get nutrition from somewhere. So what it will do, Progesterone will increase the secretory changes in the uterine endometrium. Next thing, it will preserve the pregnancy. So basically, in order to preserve the pregnancy, we need to slow down or even prevent the uterine contraction. So if the uterine contraction is there are less chances that the fertilized ovum get implanted over the endometrium. So what progesterone do? Progesterone decrease the frequency and intensity of the uterine contraction. So basically, it prevent the expulsion of the implanted ovum, and it increase the tendency or increase the chances to implant of the ovum, right? Second thing, during the transportation of the ovum is actually transported via fallopian tube. So what progesterone do? Progesterone will increase the secretion of a fallopian tube. It will also increase the secretion of the fallopian tube. And as far as the cervix is concerned, what it will do is it make the cervical secretion thick, right? And fawning pattern will be disappear that is present earlier due to estrogen. So fawning pattern is because of the estrogen, and as the progesterone come into the action, fawning pattern will disappear. Now this thing is basically necessary for fertilization, necessary for implantation, and necessary for preserve the pregnancy at the time of the actual birth. This is all the effect of progesterone over the internal genitalia. Now, as I told you, the most important action is the anti-estrogenic effect of the progesterone. So it has two anti-estrogenic effect. One is over the myometrium, another one is over the endometrium. Now what are the effect on myometrium and what are the effect over the endometrium? See, all the effect of progesterone is basically designed in such a way that pregnancy is prolonged, right? It prevent the premature labor, it prevent the expulsion of implanted ovum, right? So in order to do that, what progesterone do? Progesterone work over the myometrium. It decrease the excitability of myometrium, right? So myometrium become less excitable, so there are less chances that it become the action potential will leads to contraction. Second thing it will do, it will decrease the sensitivity to the oxytocin. Now oxytocin is basically the hormone that is responsible for the uterine contraction. So what progesterone do? Progesterone decrease the sensitivity of the oxytocin as well. Third thing the progesterone will do, it decrease the spontaneous electrical activity of the myometrium. So by doing these three function, progesterone makes sure that uterus or the pregnant uterus does not contract. Got it? It will decrease the excitability, it will decrease the sensitivity to the oxytocin, and it will decrease the spontaneous electrical activity, right? Now what it will do to endometrium? So what inside the endometrium, it will decrease the number of estrogen receptor. Got it? First thing progesterone do is over the endometrium is it decrease the number of estrogen receptor. So the effect of estrogen over the endometrium is not that much that much of good or that much of bigger as without progesterone, right? Second thing it will do, it will even make less active estrogen. How? It will increase the conversion of estradiol to the less active form of the estrogen. See, 17 beta estradiol is the most active form of the estrogen. Now what progesterone do? Progesterone will increase the conversion of this active estrogen into less active estrogen. Got it? So these are the effect of progesterone over the myometrium and endometrium. By doing this action, progesterone makes sure that pregnancy is preserved. Next thing is the mechanism of action of progesterone. As I told you, progesterone is also the steroid hormone, so its action is more or less same as all the steroid hormone. So let's summarize the steroid hormonal action, because this is I think it is the last steroid hormone that we are going to discuss. So let's see the effect of steroid hormone, how the mechanism of action of a steroid will work. Now this mechanism is 95% are same in all the steroid hormonal function. So if you do not remember from my previous lecture, just pay attention to this slide. You see in this slide This is the steroid hormone. As the steroid hormone is lipid soluble, it basically diffuse through the cell membrane. Inside the cell membrane, this hormone will bind with this particular receptor that is known as nuclear receptor, written over here. And now this nuclear receptor is basically inactive because it has a HSP attached to it. Now what is HSP? It is heat shock protein. So in inactive state of a steroid receptor is basically inactivated, or its active site is covered by HSP. Got it? So the receptor become inactive. So once the hormone diffuse into the cytoplasm, once the hormone bind with the nuclear receptor, this HSP molecule will detach from the receptor. Now what we get? We get receptor hormone complex or hormone receptor complex, and that heat shock protein, yes, it is heat shock protein HSP, it will be dislodged from the receptor. Once the hormone receptor complex will form, it make a dimer, it will just entered inside the nuclei. Inside the nuclei, this hormone receptor complex will bind with the hormone responsive element. This is HR, stands for hormone responsive element. This element is present over the DNA. So it basically the element of the DNA or the transcription portion. So once the hormone receptor complex bind with the hormone responsive elements over the DNA, it make a mRNA, appropriate mRNA. Once the appropriate mRNA will active or made, it transport inside the cytoplasm, and actual the appropriate protein will be made and appropriate changes will take place inside the cell. Alright, this is the all over action of a steroid hormone. Alright, so basically the hormone first bind with this steroid receptor HSP complex. As it will bind, it will this heat shock protein will detach from the receptor, and hormone will bind with the steroid receptor and make receptor hormone complex. And once it become a dimer, it will diffuse inside the nucleus and it will bind with the hormone responsive element. Once the hormone responsive element is stimulated, it make mRNA, and ultimately it will make appropriate protein changes. Right? Now let's write it down. Like other steroid hormone, progesterone receptor bound to the HSP, progesterone binding will release the HSP from a receptor, exposing the DNA binding domain of a receptor, and it will do its function. Now synthetic steroid, that is mifepristone. This mifepristone, or its name is RU486. It bind with the receptor but does not release the HSP. So by doing this, it will block the binding of a progesterone and prevent the progesterone action over the uterus. Alright? There is a synthetic steroid name as a mifepristone. That mifepristone is competitively bind with the steroid receptor or the progesterone receptor, and by binding this progesterone receptor, it does not release the HSP, and by does not releasing the HSP, it will block the progesterone receptor. So mifepristone is basically prevent the effect of progesterone and prevent the progesterone action over the uterus. So this mifepristone combined with prostaglandin will use to produce elective abortion. So what is the function of progesterone? Progesterone is basically preserve the pregnancy, but when we need elective abortion, what we do, we nullify the effect of progesterone by giving this competitive inhibitor, that is mifepristone. This mifepristone first prevent the action of a progesterone, and if we combine the mifepristone with the prostaglandin, this prostaglandin will again increase the contraction of the uterine musculature. So basically this combined effect, nullifying the effect of progesterone plus prostaglandin, we are going to use that both the drug, and it will lead to elective abortion. Next hormone is the relaxin. Now as far as the relaxin is concerned, is, as I told you, is a protein hormone, polypeptide hormone. It is action present in both women and men. Inside the women, it produced in by corpus luteum, uterus, placenta and mammary gland, and during the pregnancy it relaxes the pubic symphysis and it softens and dilates the cervix. It basically relax the cervix, dilate the cervix and it relaxes the pubic symphysis. It suffices the name relaxing. Thus it facilitates the delivery. Now as far as the man is concerned, relaxin is produced in the prostate gland. It is found in the semen. It helps to maintain the sperm motility and it aids in the sperm penetration of the ovum. Right? This is all about the relaxin. Now the regulation of a female monthly cycle. Now hypothalamus will secrete the GnRH nuclei, basically by arcuate nuclei or preoptic nuclei. It causes the pulsatile release of the GnRH, and this GnRH pulsatile secretion the GnRH secretion is pulsatile. It is not continuous, and that pulse physically lasts for 5 to 25 minutes. Remember this thing, 5 to 25 minutes, and occur every 1 or 2 hours. Now as far as this preoptic nuclei is concerned, as I told you in my pituitary lecture, that preoptic nuclei is basically two segment. One is the medial and one other is the lateral one, right? The medial preoptic nuclei is eventually secrete the GnRH. Remember that. So once this GnRH is released, it goes to the anterior pituitary and secrete FSH and LH, and this FSH and LH will goes to the ovary and it will increase the secretion of estrogen and progesterone. Now if you constantly effuse the GnRH, if the GnRH is constantly effused continuously, then the GnRH receptor in the anterior pituitary become down regulated, the number of receptor become decreased, and the LH secretion will ultimately become 0. And if higher frequency pulse of the GnRH is there, it will promote the LH secretion, and slower frequency of pulse will promote the FSH secretion. So if the frequency of GnRH is high, then LH secretion will become more. If the frequency of GnRH release is less, then FSH secretion will be more. Alright. Now the negative feedback inhibition. Now as far as the negative feedback inhibition is concerned, hypothalamus will secrete the GnRH. It will goes to the anterior pituitary, and inside the anterior pituitary it will release FSH and LH. This goes to the ovary and it will increase the production of 3 hormones: estrogen, progesterone, and the third one is the inhibin. Now estrogen will give a negative feedback to the FSH as well as the GnRH secretion. So estrogen has a very strong inhibitory effect and progesterone has a very little inhibitory effect. But whenever the progesterone is available, the inhibitory effect of the estrogen is multiplied. Right? It's basically the synergistic kind of action of the progesterone. Progesterone is not actually itself inhibit the GnRH release and anterior pituitary secretion, but once the progesterone is there, then the effect of estrogen is become more and more pronounced, and by estrogen decrease the FSH secretion more as compared to the LH. Now what about inhibin? Inhibin is basically secreted along with the steroidal sex hormone by the granulosa cell, and this inhibin is secreted in the same way as the Sertoli cell secrete in the male testis, right? This inhibin will ultimately decrease the FSH secretion. Now the positive feedback effect. I already discussed the positive feedback effect. Once the estrogen level in the peri-ovulatory period, the period just prior to the ovulation, the circulating estrogen will increase more than 200 picogram per ml for about 50 hours or 2 days. Then estrogen will give positive feedback signal to the LH secretion, and LH secretion will increase up to 6 to 8 times, and FSH secretion will increase up to 2-fold. Alright, this is about the positive feedback effect of the estrogen over the LH. Now what is anovulatory cycle? Now here is the interesting thing. Menstrual cycle occur at a normal interval, but ovulation does not occur. Why ovulation does not occur? Because LH surge that we need is 6 to 10 times more amount of LH secretion. If this LH surge is not sufficient magnitude, then ovulation will not take place, and that cycle is known as anovulatory. So menstruation is there but ovulation is not there. This is known as anovulatory cycle. Now when this cycle will appear, this cycle will appear in the first few cycle at the onset of the puberty. Second thing, cycle will occur several months before the menopause. So what is anovulatory cycle? Anovulatory cycle is the cycle in which menstrual cycle is present but ovulation is not occur. Now the next one is abnormalities of the menstruation. These are the list of the abnormalities of the menstruation. You just need to remember the name of the menstrual abnormalities. In gynecology, you are going to learn this entire set of abnormalities in detail. So let's mention this one by one. First thing is the amenorrhea. Amenorrhea is the absence of menstrual bleeding or the period. Second one is the hypomenorrhea. That hypomenorrhea means scanty menstruation, less bleeding or duration is less, that is less than 2 days. Now what is menorrhagia? Menorrhagia is basically abnormally profuse bleeding during the normal regular cycle. What is metrorrhagia? It is basically the uterine bleeding in between the periods. It is known as metrorrhagia. And oligomenorrhea is basically infrequent and decreased frequency of the menstruation. It is known as oligomenorrhea. Menstrual bleeding is because occur more than 25 days and remain constant at this frequency. The duration become increased. It happens in oligomenorrhea. So this is the difference between hypomenorrhea and oligomenorrhea. What is oligomenorrhea? The cycle is fixed 28 days but the menstruation is very small, very scanty menstruation, and duration is also less. In oligomenorrhea, the actual cycle become infrequent, is become more than 35 days and it remain constant at that frequency. So instead of menstruating every 28 days, the female menstruating every 35 or 40 days, whatever the cycle set. And the dysmenorrhea is basically the painful menstruation. Okay, that's it for our female reproductive function. In next lecture we are going to discuss about the pregnancy. Thank you.